Hello and welcome. Today we're diving into a condition called gastric outlet obstruction or GO. It's a blockage that prevents the stomach contents from emptying properly into the small intestine. Let's explore what causes it, how it affects the body, and what can be done about it. So, what causes this obstruction? The most common culprits are peptic ulcers, especially those located near the pylorus, which is the opening from the stomach into the duodenum. Over time, repeated ulceration and healing can lead to scarring and narrowing of this passage. Another major cause is cancer, specifically gastric cancer or pancreatic cancer that has spread to the pylorus. Less common causes include benign tumors, inflammation from conditions like Crohn's disease, and rarely ingested foreign bodies or bezoars, which are masses of undigested material like hair or plant fibers. Let's break down the pathophysiology. Imagine the stomach as a reservoir. When the outlet is blocked, the stomach has to work harder to push food through. This leads to hypertrophy, or thickening, of the stomach muscles. Initially, this increased muscle strength can compensate for the obstruction. However, as the blockage worsens, the stomach becomes dilated and loses its ability to contract effectively. Food and fluids accumulate, leading to increased pressure inside the stomach. This pressure can then cause vomiting, dehydration, and electrolyte imbalances. Furthermore, the retained gastric contents can ferment, producing gas and contributing to abdominal distension. Gastric outlet obstruction isn't something you hear about every day, but it's important to understand. While exact figures vary, peptic ulcer disease, which contributes to GO, affects millions worldwide. The incidence of GO specifically has decreased somewhat with the advent of effective medications to treat and prevent ulcers. However, with the rise in gastric cancer in certain populations, particularly in some parts of Asia and South America, an increasing prevalence of obesity, GO secondary to malignancy and potentially other factors remains a clinical concern. What are the telltale signs of GO? The most prominent symptom is persistent vomiting, often of partially digested food, sometimes occurring hours after eating. This vomiting can bring some temporary relief, but it's a recurring problem. Patients may also experience a feeling of fullness or bloating after eating only small amounts of food. Abdominal pain, often in the upper abdomen, is common. As the condition progresses, weight loss, dehydration, and electrolyte imbalances can occur, leading to weakness, fatigue, and even muscle cramp. Diagnosing GO involves a combination of tests. A careful medical history and physical examination are crucial. An upper endoscopy, where a thin, flexible tube with a camera is inserted into the esophagus and stomach, allows the doctor to directly visualize the pylorus and identify any obstruction. Biopsies can be taken to rule out cancer. A barium swallow, where the patient drinks a barium solution that coats the digestive tract, can help visualize the blockage on X-rays. Gastric emptying studies can measure how quickly food empties from the stomach, providing an objective measure of the obstruction. Blood tests are also important to assess for dehydration, electrolyte imbalances, and kidney function. While there aren't necessarily strict types of GO, it can be classified based on its cause of peptic ulcer-related, malignant, or benign non-ulcer-related. Thinking about it in terms of severity is also useful: mild, moderate, or severe, depending on the degree of obstruction and the patient's symptoms. Treatment for GO focuses on relieving the obstruction and managing the underlying cause. Initially, a nasogastric tube is often inserted to decompress the stomach and remove accumulated fluids and debris. Intravenous fluids and electrolytes are administered to correct dehydration and imbalances. Proton pump inhibitors, or PPIs, are used to reduce stomach acid production, particularly if peptic ulcer disease is suspected. The definitive treatment often involves surgery. Depending on the cause and location of the obstruction, procedures such as pyloroplasty, which widens the pyloric opening, or gastrojejunectomy, which creates a new connection between the stomach and the jejunum, a part of the small intestine, may be performed. If cancer is the cause, surgical resection of the tumor may be necessary. In some cases, endoscopic balloon dilation can be used to widen the narrowed pylorus, although this may not be a long-term solution for all patients. Preventing GO depends largely on addressing the underlying risk factors. For peptic ulcer disease, this includes avoiding NSAIDs, quitting smoking, and managing stress. Prompt treatment of H. pylori infection is also essential. Regular screening for gastric cancer is recommended for individuals with a family history or other risk factors. Maintaining a healthy weight and diet can also help reduce the risk of certain types of GO. The prognosis for GO depends on the underlying cause. Benign causes such as peptic ulcer disease generally have a good prognosis with appropriate treatment. Malignant causes, such as gastric cancer, have a more guarded prognosis, depending on the stage of the cancer at diagnosis and the effectiveness of treatment. Recent advances in endoscopic techniques, such as endoscopic ultrasound, guided gastrojejunostomy, offer less invasive options for patients who are not good candidates for surgery. Research is ongoing to develop more effective treatments for gastric cancer and to identify new ways to prevent and manage GOO. Thank you for joining me today. I hope this has been a helpful overview of gastric outlet obstruction.